Test 1 2, test 1 2, test 1 2, test 1 2.
Call this Quality and Patient Safety Committee meeting Monday, May the 13th. We'll call to order. Do we have any citizens wanting to address the committee today? No citizens. Okay, we will continue going on. And I just need a motion to approve the minutes from the February 12th meeting.
Move approval.
Dorothy moves to approve. Any seconds? Dr. Casey seconds. So we will approve. Any opposed? Okay. All right. Do I have to ask in favor or just oppose? All in favor?
Aye.
Okay. Thank you. All right. Motion carries. All right. So we will now continue moving on to our updates and reports, and we'll start with Dr. Carla Putty, who's going to share with us a patient voice.
Thank you, Dr. Holland, members of the board. I like to start these meetings with trying to bring the patient into these four walls because they are the ones that we are here to serve, and it's important to capture their voice. I usually try to bring a story. On the last 3 board meetings, there were videos of patients that we provided exceptional care for. This month's story actually is something I'm going to read out. And this story actually captures the work that the board has supported in actually improving some of our readmissions work. For some context, in August 2023, JPS started a program called the Multi-Visit Patient Program. This is a program that was targeted at trying to understand why patients readmit to the hospital multiple times a year. So with that as a background, I want to share the story with you. Prior to an ATV accident in September 2023, Mr. FR was a very energetic and full of life 20-year-old man. But after that accident, and because of that accident, he suffered horrendous brain injury. He required brain surgery. As a consequence of that accident, he had multiple complications, including seizure disorder and many physical limitations. And as of today, he requires help with eating. He cannot move his own body or extremities, and he's unable to speak. Between October 2023 and February 2024, he came to JPS 4 times requiring admissions for multiple medical problems, and each time he came, he stayed with us for many, many days. Starting October, our team, the multi-visit patient team, started to meet with this family, with this patient, to try to understand their challenges, their barriers, and what was resulting in the patient having to come to the hospital so many times. They discovered that this patient's mother had called every single provider in that insurance plan's network. And for one reason or the other, they were denied. The provider said they could not care for this patient. This patient actually needs to come to a clinic in a stretcher because they are on bed bound. They can't come in a chair there. They have to come in a stretcher, and it's very hard. And this family was really, really struggling. For 4 months, they tried. The team worked with this patient, and then finally there was a breakthrough in February. Dora York, I want to call out her name. She is called a fabulous outpatient care manager by her team. She made a key breakthrough. She was able to work and connect the patient as part of an intensive primary care program that JPS has. This is a program where we go to patients, the doctors and the care team actually goes to the patient's house and takes care of them there. And the team established the patient with Dr. Savarin. In addition to Dr. Savarin, they also connected the patient with social work, who was able to connect the patient and the family with additional community resources. Under Dr. Savarin's care, since February, the patient has been doing well. They have only come back to the hospital once instead of every other month or every month. And they are getting the best care possible at home. The patient's mother is grateful for the in-home primary care, nursing care, and improved care coordination with JPS at the helm. Navigating healthcare is a challenge. It's even more challenging when you're grieving for someone who's young and they're adapting to their son's accident. The mother said that JPS alleviated the stress and challenges the family were experiencing and by simply asking the questions that matter to them. So I just want to share this story to share the work that we're doing in treating and helping patients through some very, very difficult times in their lives. Thank you. If I could. The next part, this is my favorite part of the presentation, is recognizing our caregivers for a lot of work that they do to keep patient safety at the prime focus of JPS. Before I get to the awards, I want to call out and offer a distinction. There are 2 awards we offer here for patient safety. The first award is called the Good Catch. That's the Good Catch Award. If you look at the banner there, that's a ball they get, the Good Catch. And that's handed out to individuals. These are individuals who have done something significant to either prevent harm or to work to make sure, identify harm from happening and fixing it. So this is given out to individuals. They usually will identify a break in the system process and they would fix the process, report it up through the reporting structure, and the teams would work through the process systematically and then prevent that from happening in the future. So that's a good catch. The other award we have is actually called the Golden Mitt. It's very confusing because those 2 awards look the same. There's a ball, which is the award, and then the mitt, that's actually the bigger award. So the Golden Mitt is actually given to the team, symbolizing taking 5 fingers to actually catch that ball. So this is a team-based award, and it's actually, you can't nominate yourself. Someone else has to nominate you. And when they nominate you, they have to give you reasons as to why they're nominating you. And typically, those reasons for nominating fall into the categories of safety, improving patient access, exemplifying a spirit of continuous improvement, and then working to make daily systems of care better. So it's a team-based award for systematic improvements. I just want to call that out loud. Good Catch is for individuals and Golden Mitt is for teams. And at the board, we recognize the team award, the Golden Mitt Awards. And for February 2024, it's my great pleasure to announce the Wound Care Clinic to receive the Dr. Charles E. Weber Jr. Golden Mitt Award. They were nominated by Community Health Quality Department and the RN clinical managers for recognizing the importance of direct access and establishing a call center within their clinic to improve communication responsiveness. They took upon themselves to improve the plastic surgery rack cards and to ensure patients have essential information in the post-surgical care area. They identified gaps in wound care and perioperative service logs and improved those processes. They work in collaboration with inpatient teams and during their multidisciplinary meetings to ensure seamless transitions of care from inpatient to outpatient care. They have worked through many initiatives like the pre-ostomy site marking to make sure the procedures go well. And they have been recognized for their ongoing collaboration with inpatient teams, EPIC IT teams, to build ostomy dashboards to continuously monitor their progress. For these and many other things, the wound care team was recognized for by giving them the Golden Mitt Award for February 2024. we have tried to coordinate a better process for recognizing and taking photos, and this is the best we can do. So thank you for your patience as we do this. For March 2024, it is my great pleasure to announce the OB anesthesia team as the recipient for the Dr. Charles E. Weber Jr. Golden Mid Award. They were nominated by their L&D colleagues and the medical director by the maternal medical director for an extraordinary effort that happened one day in the OR. They coordinated an extraordinary amount of team that took care of a complex patient who had an hemorrhagic shock and received 36 units of blood. I want that to sink in a little bit. That was 36 units of blood. And for that, the OB anesthesia team was recognized and received the Dr. Charles E. Weber Jr. Golden Mid Award. Do we have anybody? They can come. I think they are in the OR operating. For April 2024, it's my pleasure to announce the winner of the Dr. Charles E. Weber Golden Mid Award to the MET team, the medical emergency team. They were nominated by the quality department, and they were nominated for the following reasons. The MET team on a daily basis serves as our critical response teams for patients and physicians. They respond to all emergencies all medical emergencies within JPS hospital. So for that, for sure. But most importantly, they recognize that as we, the readmissions team, were creating a way to identify our multi-visit patients, we created a banner in Epic to identify them, and we used the color purple. And they said that the color purple is also used to identify patients who said, please do not resuscitate me. So they found a systemic process and identified us help actually find the right color for the two patients, so we did not have any confusion. That is an example of a systemic fix that actually impacts all patients. And for that reasons, this team has been awarded the April Charles E. Weber Jr. Golden Mid Award. Take over.
Congratulations to all our winners. And every time we give out these awards, I'm always just impressed with how much our teams take it upon themselves to identify problems and come up with solutions. It's sometimes easy to find the problems. It's sometimes really hard to come up with solutions. And so I applaud them for figuring out both parts of it. And it is clearly translating to better care for our patients. So thank y'all. We're going to now move on to the QAPI, which for those of y'all on the committee for a bit, we have been discussing this for a while now. And Dr. Badamosi is joining us today in his first quality improvement. So would you mind introducing yourself first, or Dr. Carlapudi, if you want to introduce them, and then we will start talking about QAPIs.
Dr. Badamosi, please introduce yourself.
Thank you, Dr. K. Good afternoon. My name is Dr. Badamosi. Pulmonary critical care is my background, and in the last 6 years, I've been the medical director of the ICU, as well as pulmonary service, as well as the chair of the acclaimed quality committee prior to assuming the role of interim VP of quality. So I'll be talking about QAPI plan, and Dr. Holland is correct. This has come before you quite a few times, and why now? Why are we bringing this back? In 2023, last year, CMS released an interpretive guidelines for QAPI plan for all the hospitals. Generally, they give a leeway to any organization to organize their QAPI plan, so there was a lot of confusion, and to clear this up, they released an interpretive guideline for the condition of service as it has to do with QAPI plan. We did bring in our external consultant, Tchd, to take a look at our plan as it is, as was approved by the board, and they identified some gaps and made some recommendation in regards to changes that we need to make to bring us to compliance. One of those was the oversight, which ultimately belongs to this board, and the quality in the organization. One of the recommendation is the scope of our QAPI plan has to be of such complexity that it reflects the work that we do organization-wide. They felt we could broaden it a little bit. The second was the recognition that CMS wants us to include health equity in our plan, and this was also adopted by the TJC as a leadership requirement. Also, they required a project-based approach to quality. Basically, what this entails is if we identify any gap or there is a need to make a quality or performance improvement, they just don't want it to be based on best idea or this is how I saw it being done. They really want an evidence-based, methodical project that will show that any intervention is working. And before we implement those as part of our QAPI plan or continuous improvement processes. Now, this is our current QAPI plan. And if you look at it, it's really not reflective of the complexity of the organization and does not really demonstrate the scope of quality activities that currently goes on at JPS. We do more, we collect a whole lot more data. And the second aspect of this is the amount of information that is going to the MEC is a lot, and the requirement is for any information that will get to the MEC or any group should be data that they can act upon and improve and provide guidance on how to improve. And we should not be inundating any group with data that they are not able to act upon, except for informational purposes. Additionally, under this current plan, all of the committees that report to the JPS Health Network Quality and Safety Council will also present a duplicate presentation to the PSQG, which is a quality arm of the MEC. Ultimately, the information transfer to this body was felt to be too circuitous, and we could actually simplify it in a much better way. And as I mentioned earlier, it's missing health equity. Now, the last point is we can develop any internal metrics and bring it to this organization, to this board. But it's also requiring that we present to the board the regulatory data we send outside to give this board a line of sight on external comparators, metrics that are not developed internally but required either by CMS, Leapfrog, TJC, that will submit those data that will submit anyways, that this board ought to have a line of sight on that as well. This is our proposed QAPI plan. And if I may draw your attention to the bottom three boxes that shows committee, programs, and department, we've tried to organize it in a way that it actually captures with broad intention all of the quality programs that goes on at JPS. And if you look at the second box under program, you will see health equity as well as quality and regulatory report, CHIRPS and TIPS, which is a state program, CMS star rating, Leapfrog, MIPS, NHSN, as well as PAE that is reported to the state of Texas. And in the last box on the right, you will see departments that are big that usually will have their own independent quality programs going on just because of how specialized they are in those departments. And all of those will report to the JPS Health Network Quality and Safety Council, which will now report in summary fashion to the PSQG most of the medical related quality activities that can be acted upon directly by MEC. I would also like to point out the bidirectional arrow between MEC and PSQG, as well as PSQG and JPS Health Network. That reflects that we also receive input from MEC as a body on a monthly basis based on summarized data that we provide to them before it ultimately comes before this board. So we do believe that this proposed structure meets the requirement for, based on the interpretive guideline of CMS on QAPI plan. And we will be required, this is a voting item that under the section 5, we'll be requesting a vote and approval for. Any questions, Dr. Kim?
No, I was going to ask it.
I'm following a lot of the bidirectional arrows. Obviously, we report to the Board of Managers, but they're not necessarily directing us or the MEC. I'm just wondering if there needs to be bidirectional arrows between the committees, programs, and departments to the Quality and Safety Council. Shouldn't that be a bidirectional relationship? Like they are reporting up, but also they are being given direction down?
Definitely. I mean, we can do that because in practice, that actually is what's going on.
I think everything else looks good in that.
Totally agree. It's like a continuous feedback loop
Correct.
of that we are giving each other. So appreciate that. Yeah. I think this is.
Just start arrowing everywhere. No, but that's the only area I can see that.
I just want to say that if we were to capture all the committees and all the work, it might take an entire 4 or 5 slides. So what you're seeing there is a representation that captures a book of work, but there's a line there that says other committees as required, which is actually captures a lot of the work. I think this will bring to the board's attention information that is quite vast and quite varied and actually very comprehensive of all that happens in quality. In healthcare, it is natural to think that all quality is clinical quality, which is most of our work, but any work that makes a process better is actually quality improvement. That could be happening in finance, that could be happening in contracting, that could be happening elsewhere that's not clinical, but all that needs to come up here because ultimately it still impacts quality for a patient somewhere.
Different boxes. There's so many activities going on. I think this is the first time we've really intentionally put them in some sort of categories. I suspect the next one will not. Some of the next few years won't look much different because this is a lot of work into getting this.
Yeah, I have a feeling once we start putting this into action,
Yeah.
and you realize all the players that these committees, programs, and departments lists are going to continue to grow. So, but I do think it's kind of
And adopted by Joint Commission that they're going to hold are identified organization-wide is really aligned to strategic goals and priorities, and really it's data-driven and methodical analysis is conducted, and a solution that is really objective is what is being applied on a continuous basis to drive the process improvement that we need as an organization. And we do have an example of that readmission, and there will be a little bit more information in subsequent slides. I think this is the last slide I have for cooperative.
Okay.
So to stay on topic, we'll go ahead and vote on this version of the QAPI plan. Are there any questions, concerns about it as is? Can I entertain a motion for approval of the QAPI as presented today?
Move approval of the Quality Assessment Performance Improvement Plan.
Second.
Second.
All in favor?
Aye.
Any opposed? Okay, so it is. Motion passes. All right. Now we can move on to quality dashboard.
Thank you. The next slide I'll be presenting, thank you for the approval, will change with subsequent presentation now that we have a new QAPI plan. But I felt this slide is particularly important for us to show because this is the first time that HAIs, or healthcare-associated infection, all of our dashboard for this specific metrics is green. And I would like to also highlight the catheter-associated urinary tract infection. Today is day 96 that we've had no catheter-related urinary tract infection network-wide. This is really a remarkable achievement for the organization and reflects the work that has been conducted in multidisciplinary fashion with both our nursing staff, physician, as well as non-clinical staff. So I thought I should highlight that to the board.
Can I say something, Dr. Barron?
Yes, please.
So when I first saw this dashboard, I asked the question, when was the last time we had green consistently across the board? I said, it's been a year, 2 years, 5 years, 7 years. I have not yet met someone who has seen a quality dashboard at JPS where it was green through and through for an entire year. I think when you look at colon SSIs, colon surgery, surgical site infections, Dr. Stevenson, who's our surgical quality officer, said that he's been here for 11 years or 12 years, he's never seen it. So that excellence happens because every day there is a team with the patient that's trying to prevent a hospital-acquired condition from happening. It does not happen because of luck or chance.
And our numbers of admissions and patients didn't go down, so that, sometimes it gets better when we have less patients, but this is great. Congratulations, everybody.
Thank you.
Thank you.
I really like this slide too, just because it elaborates what y'all were talking about in the previous slides of how all of this interplays together, our CMS star ratings, our leapfrog scores, just the desired targets, the complexity of what we do here. And so I think this is great.
Thank you. A little bit more deep dive and updates regarding some of the priorities that were identified earlier on as quality priorities for 2024. This is our CLABSI rate. Today is day 48. We've not had a CLABSI. We are still working we really want to sustain that. And our goal, as Dr. K keeps reminding me, is 0. So we will continue to push for that. Our SIR is currently 0.8. I would like to point out that by looking at external comparators, nationwide, a lot of organizations have also made significant improvement in their HAIs just because of the significant penalties that are associated. So you will find out that the SIR of our comparators is also going down, but we are going down faster than the national average, which is exactly where we want to be. As Dr. K mentioned, same for colon SSI, a lot of work was done here, glycemic control, pre-op antibiotics, improved documentation practices. This is still ongoing in a multidisciplinary fashion, and there's a lot of hardwiring of all of these improvements that's taken place organization-wide. Same with our total knee. We've only had one in this fiscal year, and our SIR is currently uncalculable. Abdominal hysterectomy as well is showing significant improvement. As you can see on your slide, it's basically been 0. Now, length of stay. Our length of stay has made significant improvement. And really, and if you talk to everybody across network, everybody can actually feel the impact of this work that is ongoing at the highest level of the organization, led by our 2 ACNOs and ACMOs. They have done a fantastic job putting together a multidisciplinary group to work and tackle this. How have they really made the success happen? I will explain in subsequent slide, but you will see that sometimes the question is always asked, if we are reducing our length of stay, are we discharging patient out of the hospital early? So we need to see what our readmission is, because if our readmission is going up, that will mean actually we're just pushing patients out. On this slide, you will see that all-cause 30-day readmission, which is also an AIP goal, is actually coming down, which means the processes and the interventions that have been put in place by this work group is actually achieving the desired result without necessarily increasing harm to patient by way of increased readmission. How have they done this? What have been the strategy? To reduce length of stay and readmission, you really have to target either a patient population or a disease state, and this has to be informed by the data. So they have decided to target both. They identified, as Dr. K mentioned earlier, our multi-visit patient, which really is patients that have been admitted on a rolling basis, 3 or more admissions to the hospital. And they decided to tailor their intervention to this group of patients after studying them. And they conduct daily assessment for all MVPs that are admitted or in observation. And there is a lot of care coordination by our case managers, as well as leveraging both internal and external by way of community programs to support MVP needs. Most importantly, they pay a lot of attention to transitions of care, which usually is where the problem is. How do we connect this patient to the care they need on an outpatient basis? I think they have been able to come out with a robust solution for that. I would like to highlight that this group of patients, even though they constitute a small minority of patients, but they are responsible for about 30% of readmissions. So targeting them is actually very, very important. In terms of, so you can see the readmission for the MVP population based on all of the intervention is really downtrending from a baseline of about 33%. The initial target that was set by this group was 27.5% when they started their work. And you can see through the month, since the beginning of the fiscal year, they have actually shown that the percentage of MVP as part of the overall readmissions have actually dropped down to 16%. Here is some of the detailed intervention that they have that was instituted to achieve these results. They designed a program, they studied the patient, and they launched an EPIC Compass Rose, which basically ensures that detailed information that will need to be seen by both inpatient and outpatient provider is able to cut across both contexts. Usually, if you log into EPIC, you do have an inpatient context. I can see a lot of prior admissions, a lot of intervention, a lot of plans of providers on the inpatient. But in the outpatient context, if you log in, some of those information are missing, or you really have to dig deep. So with what they have done, there is a care coordination note for this MVP care plan, so that any doctor seeing them on the outpatient or provider will be able to see what was the thought processes and the plans of the inpatient providers for this patient. And that really ensures that care transition is effective and there is no information loss when this patient are being seen on an outpatient basis. The other thing I would like to highlight is substance and alcohol use also really impacts the MVP patient. About a third of MVP patients here in JPS actually have some substance or alcohol use. So they have developed a program, the SBIRT, that really ensures that patients are assessed and there's a brief intervention performed on both of these issues, and a referral is facilitated to specialists that can actually help take care of these patients. Now, as I mentioned earlier, there are two targets potentially, or in all situations, to target to reduce readmissions. One of those is targeting the patient, and the second is targeting a particular diagnosis. There's a lot of readmission that is driven by heart failure as a DRG, and it's the number one DRG that is associated with readmission. And this, the group have also developed a heart failure program that targets this particular patient population. Every time a patient is admitted with heart failure, there is a nurse visit, the heart failure nurse that goes to meet with them and evaluate, develop a coordination care plan for transition to outpatient, especially being seen at a cardiologist clinic within 7 days of discharge, as well as at the time of discharge, before the patient leaves the hospital, they actually get handed their medication so that they will have medications available to them when they go home prior to being seen in the clinic. And most importantly, there's also follow-up calls and touches with the heart failure patient, and additional education provided to heart failure patients in the clinic. What has been the impact of this? You will see that currently, for the patient enrolled in the heart failure program, the all-cause readmission rate is around 16%. And for patients that yet to be captured in this program, the all-cause readmission is around 21%. This is objective data that all the intervention that is being carried out by this team is having a lot of success. And the goal is to actually spread this program and capture all of the patients with heart failure into this program so we can see the same benefit. A lot of lessons learned, both based on patient populations as well as disease specific. We'll hope the plan is to actually look at other populations in the hospital as well as other diagnoses that can also be impacted based on the lesson learned with these two major interventions. All right. Any questions?
One comment on length of stay, and that's not obvious sometimes, is when we decrease our length of stay from 5.94 to 5.3 last month, it creates additional capacity that you did not have. Hospital beds are very expensive to build, so one of the ways to be more efficient is to actually make sure those beds are utilized well. And my friend Rory is behind me, and he'll correct if my numbers are wrong here, because I'm not a math guy. But since we started this work, because of our efficiency and actually discharging patients more efficiently, it's my understanding that we have taken care of 680 patients more than we would have done if we had not done this work. And when you take care of 680 patients more, it adds more revenue to the bottom line that we would not have it before. And if I'm not wrong, the revenue so far from the length of stay work is close to about $6 million.
Well, that would also show up in the length of time the patients are staying in ER waiting for a bed. Remember, that becomes an issue too.
Correct.
So that would impact that. So I know we'll get a report on that.
Yep, our left without being seen rate, Dorothy,
That will be-
is below 3%. I think the last check it was 2.3%. May was a tough month, but otherwise we were below 1% at some point.
Right. But I think we also had some concerns there for the length of time it was taking a patient once admitted to get to a bed. So with this should show a decrease in that wait time. Okay.
Absolutely.
I'm curious who makes up the MVP work group. You mentioned a group, but like who's in it? And I'm imagining it's both inpatient and outpatient that you're following these patients.
Right.
Just curious who's
So
doing that.
is Dr. Assad here? Yes.
Yes.
If I get this wrong, Dr. Assad, please correct me. So we have Dr. Assad who leads a team. They meet every day. They get a list of every day. The case managers get a list of patients who fall in that criteria of MVP. Each unit's case manager rounds on these patients. The physician who's the attending will round with the case managers, and they all huddle around this patient. Inpatient case management, outpatient case management. Sometimes they even bring in the outpatient primary care doctor because they're going to be accepting that person's care. We want to do a warm handoff to them. So it's a sizable group of people who come together and they meet about these patients in real time. So they're trying to create the plan. And once they create the plan, they articulate it in a note so that is visible to most people when they see the patient coming back. You want to have the same care plan consistently so the patient gets the consistent care. So yeah, it's a multidisciplinary team. I think they have physical, depending on the patient needs. If the patient needs respiratory therapy, they have them. If they need physical therapy needs, DME needs. So it's a large group that comes together and meets every day.
Is the family a part of that group? Is the family, when they all come together, is a family member that would help for them to hear the information and see what's happening to their loved one, and they could be making plans for when they come home?
Absolutely. It's very hard to make those complex plans without the family. It's very important to make sure that everybody's aligned because these patients have some complex, challenging needs and needs everybody to bring together. Sometimes we even bring social work and then understanding what kind of resources we can bring around the patient and the outpatient. So outpatient social work comes in to figure out what do we need to bring and bolster the support. And
I'm just curious, kind of the major reasons that the patient, you gave the example of the patient experience at the beginning, and I'm imagining it's pretty patient dependent, but are there some major consistencies with this particular patient group that we have them come back month after month to be admitted?
Yeah, I think it's very hard because, so 131 patients account for 690 readmissions last year. So it's a very small group of patients who account. And each one of them is very unique, so you can't categorize them. But what we found out is substance use, behavioral health, mental health, and then complex medical problems. When you have heart failure, diabetes, and a behavioral health challenge, it becomes, and then access to care. So I think what the team tries to do is figure out where the barriers are. The other thing to notice specifically with this patient population is I call them the most valuable patient and the most vulnerable patient, because what happens is if you have come into a system and for the last 5 times you have gone through the same experience, the patient becomes numb. They kind of anticipate this is what's going to happen. So essentially it takes the team to have what I call a mind switch. You have to ask a patient the question that matters, not from the care team's perspective, but from the patient's. And that takes time. That takes a lot of deep thinking. And that's why it's good to have so many people in the room having that same conversation, and family members there too. Otherwise, we miss that perspective. So I think more than which category they fall into, it is developing an emotional quotient to asking patients the questions that matter. And our experience has been substance use, behavioral health, and just complex medical problems that have complex needs.
And then to change directions on the heart failure program, I love the idea that the patients have their medications before they even leave the hospital. In my experience, heart failure, that's the main thing, because usually meds are changed significantly during the hospitalization. How are y'all doing that? Is that through the JPS pharmacy?
Yes, we have a meds to beds program that's quite unique, and we have a very good turnaround time for getting meds to patients before they leave. It's a very efficient, lean operations, because we discharge 80 to 100 patients a day, and we make sure that all those patients have meds before they go home. So yes.
So you're doing this across the board, not heart failure specific?
No, it's
that's amazing.
all patients. Yeah.
I think that needs to be highlighted.
Yeah, I experienced that with my sister last week, and it was fantastic. They even brought a little credit card machine, so you could make your payment and everything else. It was fantastic. It made discharge very, very easy instead of sending them back down to the pharmacy, make those changes. But while they were doing the discharge, everything came up.
Yeah, especially since patients are discharged after hours and on weekends, and sometimes the pharmacy's not open. And so to go without your Lasix for those days, or whatever your needs are, it's a big deal, and it is the difference between them being able to stay at home and come right back. So,
Absolutely.
yeah, awesome. That's wonderful. Any other questions about quality priorities?
All right. So with the approval of the QAPI plan, we will subsequently be bringing before the board, as we should, a lot of patient safety event. We feel it's appropriate to actually let you know what our processes is, how we evaluate and manage these patient safety events, for your information as well as feedback to us. Because we will be referencing this going forward as we present to the board. So a risk event is identified by a team member. We use the MIDA system. That is the electronic system that we use to document any risk or any gap that is identified in care. This will be entered by a team member. Also, they can call the patient safety hotline that is available 24/7 as well. Once this is done, the patient safety specialist will take over the case and identify or determine if there is a deviation from generally accepted performance standard. If there is no deviation, then it will be rated as not a safety event, or it's a known complication of the procedure, test, or whatever was going on with the patient at that time. If there is a deviation from accepted performance standard, that the deviation reached the patient. If it did not, then it's rated as a near-miss event. If it did reach the patient, they did cause moderate to severe harm or death. If no, then it's rated as a precursor safety event, and if it did, then it's a serious safety event. So we will be referencing in our subsequent presentation this HPI SEC process of serious safety event, precursor safety event, near miss event, or not a safety event, or a known complication. Now, if at any time the patient safety consultant is not sure, there is a group of patient safety consultants with their director that meet to actually review the case on an individual basis and make recommendation on how to classify the safety event. Now, this is the table that they all have in front of them that further helps in really stratifying and determining the level of harm that has caused the patient. And you can see on the left side, there's the near miss way at the bottom and the precursor safety event as well as a serious safety event and various degree or various level of harm to the patient. Now, the standard process to classify the work is developed depending on the severity. What do we do once we identify any of those safety events? Depending on the nature of the event and severity, an apparent cause analysis, ACA, will either be initiated if the cause is really simple, obvious, and we need to do something quickly about it, or a root cause analysis and action. That's the RCA2 process that we currently use to analyze and develop specific action plan with action plan owner and a time of delivery and process of hardwiring and sustaining all of those action plan and disseminating the same information to the frontline staff or where system-wide it will need to be domiciled. All right.
Any questions?
Any questions?
As you think about questions, one of the things we wanted to articulate in this presentation is to provide you a clear process as to how concerns are brought up to the organization's awareness, and then the consistency of the process that the teams follow in order to get to the consistent outcome. Sometimes, if teams don't follow a consistent process, you can end up on very different sides of what the problem is. But we have a very consistent process. And the other thing I want to reiterate on the action plans, when our teams come up with an action plan, they assign an owner, and the owner is provided the resources and the time to complete those action plans. And then once we complete the action plans, we actually audit that the action plan is getting done. And we do it for a period of time. So based on the action plan, it can be 30 days, it can be 90 days. But that's not enough either. So we go and audit the action plans a year out to make sure that those action plans and those processes are actually hardwired. So it is a very rigorous process to make sure that once we have a problem and we have figured out the solutions are audited, monitored for a year out. So, and that's not usual. Usually most places stop at 30 days and say that's enough, but we do it for a year.
Now, some of this report, this slide is showing the mandatory state and federal reporting that we have to report anytime they happen, and we will be bringing some of these to the board as well. So the preventable adverse event, this is reported to the state of Texas. They have specific definition. If it happens, they are deemed preventable if we have appropriate measures in place. We report this to the state, and we will be referencing this in our presentation to the board subsequently. Also, report of ambulatory surgical center transfers. As an example, if any patient goes for a procedure at JESCA and they have to be admitted or transferred from JESCA to any hospital, it is reportable. And the other is abuse, neglect, and EMTALA. Those have to be reported as well. And in cases of EMTALA, not just a violation by the hospital, but also any report that a hospital files because we found or determined that potentially there is an EMTALA violation by another organization. The next one is the reportable death in restraint. This is really a tricky one too, that one will have to consider carefully. Most of the deaths that occurs in restraint have nothing to do with the restraint. And it's usually a terminal patient that is pulling on IV line, usually level C, DNR, comfort measures only. And they have to have a meeting just to reduce, but that is considered a restraint and it's reportable. So we dissect all of this, but usually there is no action. And if we bring this to the board subsequently, this is one of the contexts that we'll have to highlight during our presentation. Medsun report is FDA program. All of the major medical product equipment devices, if they malfunction, this is a formal way of notifying FDA so that they will be able to determine if there is a systemic or prevalent issue with that particular product or device. And so we also provide this report to the FDA, and we'll be sharing some of those with this board as well subsequently. I believe this is the last slide of my presentation at this time.
These are all reportable. Is that to the board? Is that to the state, the federal government?
State and federal government, yeah, perspective.
These are mandatory reporting. If we ever have it, we have to do it. And I think we are very good at reporting them when they happen. We've got a very good process to make sure they're done.
I think just the kind of overall theme is to create a culture of reporting and just, on every level. I find in larger hospital systems that inpatient, it's a culture that we're really good at reporting, but outpatient, it's not so much of a culture. Surgical hospitals, not as much of a culture. And so that on all levels, that there's just a culture of reporting and to understand that it's not punitive, it's defined better processes so that, these things don't happen again, to learn from our mistakes and get better from them. And so, I think that's wonderful.
I just have one question. I like the process, but I'm in with a loved one and I see something that I believe is putting my loved one at risk. How does that fit into this plan?
Like a patient report.
Yeah, I'm with my loved one and I am seeing something that I believe has put my loved one at a risk. So what happens when I notify the nurse or whatever? How does that get, or does it get reported? Maybe that's the best.
So two processes, either the staff on the wards can be notified and they will enter in the MIDAS if it's appropriate, or they can call the patient complaint line and that will also be taken up and they can call the patient safety who can enter the MIDAS themselves.
Okay. All right, okay. And so if it's a patient that a family member that need to call this hotline, is it posted in the patient room? How would I know to call? I'm just asking that if you have a plan and you say, okay, you have a patient hotline, is it posted in the rooms, like when you go to, I can only talk about when I hold an election, I have to post a sign that says, if you have a complaint, you can call. So just asking.
Yes, it's usually in the booklet that the patients are given when they come into the hospital. But in regards to whether or not it's posted, I believe I've seen some sign, but I'll need to double check and get back with you on that.
It'd be also nice to know how the patient and the family member involved in the process, just so that they're reassured that they were heard.
Yep.
That it was being acted upon.
Because we will get it back, because it'll come out in the patient. They always say, if it's bad, they're going to do that survey. If it's good, they might not, but it's bad, I'm going to do it. So.
We voted on the first matter requiring approval. Now we have two other items up for approval. Dr. Badamosi, you're going to present on the infection prevention and control program.
Yes, ma'am. This is an existing policy that has to be brought before you every year for approval. It's IC1. It deals with infection prevention and control program for the organization. Basically, it outlines a plan for infection prevention and how we'll deal with outbreak at JPS, as well as a risk assessment organization-wide by our infection prevention specialists to identify areas of vulnerabilities and what our plan is. Additionally, it also sets goals for hospital-acquired infection or any other priorities that is identified based on the risk assessment. So that is the summary, with particular focus on high-risk services, high-risk population, and very high priorities area. There's a red line version of this in your folder that shows that most of the changes that's been done is really consolidating the document, reducing the number of pages that it is, and capturing most of those information in the first 5 pages of the document.
Are there any concerns, questions about the infection control program? Is this already brought to the medical committee?
Yes, ma'am. It's already been brought to MEC. MEC has approved.
Okay, move approval of the Infection Prevention and Control Program Authority.
I get a second? Anyone opposed? All in favor?
Aye.
It was Amanda. We just have one more, and this is on management of hypertension with the obstetric patient.
Yes, I'm bringing forward PC 4100, management of the severe hypertension in the obstetric patient. It is due for review and approval. We had some minor word and sentence edits, but no content changes, and this is in alignment with the Joint Commission requirement, PC Chapter 06.03.01.
Any questions about the new policy or updated policy? Can I get a motion to approve?
Move approval of the management for severe hypertension in obstetrical patient.
Get a second? Second. Dr. Casey seconds. And all in favor?
Aye.
Any opposed? Okay, so we will move to approve the policy. I think that is all we have in our open meeting. Any additional questions, concerns? Okay, so I will move to close the open meeting, and we will open again in
meeting